So I want to say welcome again to the HIMP Friday seminars. We're excited to have you here with us today. And on behalf of the University of Victoria, we acknowledge and respect the Lekwungen, Songhees, Kapasim peoples on whose territory the university stands, and the Lekwungen Wasanich peoples whose historical relationships with the land continue to this day. I know that many of us are joining from other places, and I encourage you to spend a moment to think about your relationship with the land from which you are joining and your relationship to the peoples of that land. And as we move ourselves forward in health informatics, I hope we are also thinking about the work that we do and the relationship it has with reconciliation. On that cheerful note, I will go ahead and turn it over to our speakers for today. They have asked that you hold your questions to the end. However, we have a Q&A box, so it means that you can type away while they're talking, and your questions will be right there when they finish. Feel free to type. If you are typing in your question during the presentation, I encourage you to give just a little bit of context, because if you say, oh, and what did you mean by X, they may not know what slide you're referring to. So if you could put just a tiny bit of context in, that really helps. Otherwise, you've probably discovered, especially since I know a bunch of you are regulars, that we don't have use of the microphone or the chat box. So your Q&A box is your way to interact with us today. All right, thank you. I'll let you take it away.
Well, I'll just start off the presentation. My name is Gina Dimitropoulos, and I'm a professor of social work at the University of Calgary. And I have the privilege of working with my two colleagues who are on the call, who will introduce themselves soon. But we are also presenting on behalf of a very large team. This work couldn't actually be possible without having close collaborations with the Recovery Alberta and the University of Calgary. We've partnered together over the last 5 years, and the funding for this work comes directly from the Alberta Children's Research Institute. So I'm going to be starting off with giving you a little bit of information about the project and the framework that we're using. And then Karen Moskowitz and Leah Norman will speak a little bit about some of the preliminary findings that's emerging from our work. So the title of our talk is Digital Measurement-Based Care within a Stratified Model for Emerging Adults within the context of a mental health care. And we're going to talk about some gaps, opportunities, and advancing practices. And I also would like just to take a moment to acknowledge that the work that we have been doing and where we reside and live our lives, we're located in the heart of southern Alberta, which acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Piikani and the Kanani First Nations people and the Tsuut'ina First Nations, Stoney Nakoda people, including the Chiniki, Bearspaw, and Goodstoney people. The city of Calgary is also home to Métis Nation within Alberta, which includes the Métis District 5 and Elbow Métis District 6. We're all grateful to have the privilege of living on this land, and I want to acknowledge the historical and ongoing colonization and traumas that Indigenous people experience and want to do better by making sure that we are good allies and continuing to do the good work and move forward in a way that benefits all people, including Indigenous people, First Nations, Inuit, and Métis. So we have a couple of objectives that we hope to cover in the next 45 minutes. And the first one is to really speak a little bit about what we mean by emerging adults and the context in which they are attempting to access services and some of the challenges they experience as a result of the mental health system being siloed and fragmented. And then we're going to talk about the context in which we've been doing some work that's focused again on the use of a stratified care model that also brings in measurement-based care to identify how we could better meet the needs of diverse groups of mental health, young adults with mental health issues. And then finally, we're going to talk about a co-design approach that we've been using to develop what measures to use and when to use them, how to use them in collaboration with emerging adults and other interest holders. So I'm going to give you a little bit of a background of the work that we're doing, and I'm going to assume that many of you probably already know a lot about emerging adults, but I'll just share a little bit about why we feel this is a very important group to focus on. And thank you so much, whoever is managing the slides for me. I'm so grateful, and you're doing a great job and always on cue. So thank you for that. So I just want to, for those who may be unfamiliar with this, emerging adults is a term that was coined by Jeffrey Arnett, and there's a proliferation of work that's been done in the last decade or so on what's unique about this stage of life. And Arnett's work and many other people have really kind of seen this as a time in a period of young people's lives when they feel like they are experiencing many psychosocial changes. They're going through many relational changes. They're launching into different areas of their lives where they're thinking about education, work. Their identity is becoming more solidified as they have more opportunities to explore and think about who they want to be and how they want to live their lives. So this is an opportunity that we see as where there's lots of excitement and lots of opportunities for people to really be have gain more independence. But this is also a time in life where many young people experience increased vulnerabilities, and sometimes those vulnerabilities are exacerbated because of systemic challenges and inequities. And indeed, the research does suggest that approximately 75% of lifetime mental health disorders often present themselves before the age of 25, making this time period a really critical one where we can think about early interventions and providing the right kind of treatments to meet people where they're at. So this highlights that emerging adulthood is a critical time period where there's a window of opportunity for us to really support those who are developing new mental health issues or having a recurrence or have more acute and chronic mental illnesses. And there's been lots of great work that's happening and thinking about how to transform services so that we can better meet the needs of emerging adults. But many young people will describe experiencing many barriers to accessing services and delays in help seeking. Uh, and early disengagement from care are common and are often really shaped by these system level barriers that we see, such as long wait times, restrictive eligibility criteria, financial constraints, and stigma, sorry. And in response to these system level challenges and barriers, our team has been thinking about how we can use stratified care and embed it within routine clinical care to ensure young people are receiving the right level of care when they need it most, but that we also have a system of care that is designed to help respond to maybe changes in symptoms presentations, or maybe because of social determinants, people's circumstances have changed and they need something different. So we see stratified care as a way to really think about how to better meet the needs of emerging adults. So stratified care is a clinically staging informed model that aims to better match treatment to an individual's level of need and also recognize the changing mental health needs that often people experience. And next slide. So rather than offering a one-size-fits-all approach, stratified care allocates treatment across a continuum from low to high intensity services. So based on an individual's symptoms profile or their readiness, fit, an overall level of complexity, we can be better able to respond to where people are at. And as individuals' needs change over time, they may be moving between different levels of care, allowing for services to be more responsive and for us to identify ways to personalize how we are providing care. So stratified care allows us to span the full care pathway from intake to discharge, with decisions about care intensity made and revisited across at different time points. And while stratified care provides a structure for matching individuals to appropriate level of care, it also raises important questions about how do we do this and how do we do this systematically in a way that allows us as providers to assess and monitor how mental health needs might change over time. And one approach that maybe, well, has gained a lot of traction and attention is the use of digital measurement-based care, which is what we've been trying to do, which is to determine whether measurement-based care within the context of stratified care might be a way of more successfully meeting the needs of emerging adults. And just really quickly before we go to the next slide, I just wanted to say a little bit more about digital measurement-based care, which involves the systematic collection of individual reported outcome measures across a number of different domains, typically used through an online platform. And the platform we've been using is called Inowell, and it's one that has been widely implemented across Australia. So we've been working with this platform or using this platform the last 5 years, but we are agnostic and not necessarily saying that it's the platform that anyone should use. It's just the one that we've been using to help us to test out the implementation of measurement-based care and also the stratify model. So digital measurement-based care really enables clinicians to collect data on symptoms, level of functioning, well-being, wellness, and other psychosocial variables that can really be tracked over time rather than just capturing data at a single time point, which is often what happens. I'm also a clinician. I've worked in the healthcare system for a really long time, and often we use measures at one time point when a young person comes in, they complete their assessment. But in order for us to be more responsive and really recognizing that symptoms and life circumstances fluctuate, we're hoping to think about how to, we can embed measurement-based care at different time points so that we can capture when do things change and and as people's symptoms either improve or deteriorate, how can we better respond to make sure that also the level of care that we're providing changes as well. And next slide. So the theory behind kind of our work is that stratified care is designed to be used across the continuum of care to match the intensity of an intervention to symptom profiles, level of need, while also adjusting care over time as client needs change. But the practical reality is that stratification decisions are really hard to make because they're often treated as if they're static and not applied in a flexible and collaborative way with young people. So, as I said, many services, at least that we started working with here in Alberta, we found that they often would capture measurement-based care that have one single time point or one intake point and not know or have the capacity or the resources to be able to embed measurement-based care across the system from intake to different, maybe when people complete different interventions and at discharge, and maybe even following them over time to see if their symptoms change and help to signal to the young person that maybe they need to engage in help-seeking behaviors again and access services. So this is all kind of helped us to identify that there really is a gap in thinking about how to operationalize stratified care and how to embed measurement-based care across the continuum of services. So through our research, we're truly trying to address this missing infrastructure for the right care at the right time, and also recognizing that the right time really does change because what might work at one moment might not work so well at another. And what we've also realized and what we want to try to address, there's often an absence of iterative feedback loops that are used within clinical care to assess when changes happen. And we're hoping that by using a digital measurement-based care approach, we might be able to really test out the stratified care model that is meant to be more dynamic and data informed and a way of capturing data that can be really used in real world service settings. And so we're excited to share with you today some of the learnings that we've had by engaging different interest holders from young people all the way to administrators and leaders to hear about how we can successfully implement stratified care through the use of measurement-based care.
Thanks, Gina. So I'm going to share some background information for our study, and then we'll move into sharing the quantitative and qualitative findings. So the main objective of our research is to evaluate the feasibility and acceptability of digital measurement-based care. And in some settings, this occurred within a stratified care staging model. Moving forward, I'm just going to use the acronym DMBC. It's a lot easier. So we're using a concurrent multi-methods design where we're collecting and analyzing quantitative and qualitative data at the same time. And this allows us to capture the measurable aspects of implementation, like rates of youth engagement in DMBC, as well as the qualitative perspectives of our participants. And we're also using a rapid learning health system approach where data from participants who use DMBC is evaluated on an ongoing basis to help guide implementation. And this creates a feedback cycle where the data is analyzed and then it's quickly applied to enhance care and support collaboration between clinics and the research team. I'll provide a brief overview of the stratified care model that was implemented in some of our settings. So we first worked together with community and clinical collaborators to select a digital health platform, which Gina mentioned. It's called Inawell. And so the platform that could deliver a battery of patient-reported outcome measures related to youth mental health, physical health, and overall well-being. The platform was then implemented in a variety of clinical settings. We then identified how to use client data from these outcome measures to guide treatment stratification and provide youth with the appropriate level and the appropriate duration of care. Participating clients were then onboarded to Inawell. They completed the battery of assessments to establish their baseline. And throughout the study, the clinics would have weekly case conferences where they would review each client's platform results, their case history, and any referral information to determine which treatment intensity was best suited for that particular client. Case reviews would then be conducted every 3 to 6 months to decide if a client is ready for discharge or if they require a different level of treatment based on the results of ongoing measurement-based care. So today we're going to be talking mostly about our qualitative findings, but just for an overview of some of our quantitative data collection. This slide here is showing all of the different areas of young people's well-being that were measured in the online platform. So for example, anxiety, depression, eating behaviors, and it's also showing whether they improved, stayed the same, or declined during treatment. This particular data is from 53 young people. And from this sample, the areas with the most improvement over the course of their treatment were depressed mood, everyday functioning, and psychological distress. So I'm going to pass it over to Karen now, who's going to provide an overview of our qualitative data.
Thanks, Leah. So to introduce our qualitative data collection, for the next few sections, we'll share qualitative insights gathered from leadership, providers, and emerging adults. In this slide, we will review the qualitative data collection by briefly overviewing the participant recruitment and data sources. The leadership and provider participants were recruited from various service settings across Alberta that adopted only the DMBC platform. The emerging adults were recruited from 2 mental health clinics in Southern Alberta that engaged with DMBC platform in stratified care. There was a good range of participants at both time periods, and these are the groups of individuals that we will share the qualitative findings from. Across the study, we did numerous focus groups and interviews. In 2024, we had 64 individuals to participate, and they were made up of leaders, service providers, and emerging adults. And then in 2025, we conducted another round of focus groups and interviews, and this time 60 individuals participated of leadership roles, provider, and emerging adult roles as well. Qualitative analyses used various methodologies such as thematic analysis and rapid qualitative analysis. All analyses followed an overall qualitative descriptive approach, which means that we intended to remain as close as possible to participants' own words about their experiences. Before we move on to the findings, I want to briefly orientate us to the key demographics, including key characteristics such as age, gender, and other relevant identifiers. For leadership, a majority was based in rural specialized mental health service sites, older or equal to 30 years of age, and most identified as women. For providers, they were primarily social workers, case managers, and psychologist counselors, with a majority based in rural specialized mental health and school community-based settings. Most were aged older or equal to 40 years of age, and most identified as women. For emerging adults, ages range from 17 to 24 years of age, with a gender-diverse sample, including women and gender-diverse individuals, with a balanced representation of students and employed individuals. I've grouped our findings into 2 broad themes that highlight the key factors shaping implementation across sites. The first theme here looks at the structural and organizational factors that shape how DMBC was taken up and sustained in practice. We heard a lot about resources and infrastructure limitations, limitations including limited funding for staff and clinical devices, as well as the absence of or limited availability of dedicated roles to protect providers' times by taking on administrative tasks. These tasks included onboarding clients, supporting EA's engagement with platform, and troubleshooting technical issues. At sites with adequate resources, staff and client engagement were higher. These challenges were compounded by the introduction of other major organizational changes, including the transition to our province-wide clinical transformation system called Connect Care, and ongoing service delivery demands. Leaders described difficulty balancing these competing priorities within already stretched times, and contributing to the administrative fatigue, of course, and reducing capacity for change truly. Importantly, hesitancy or resistance was often driven by limited capacity rather than a lack of interest in DMBC. Lastly, leadership and staff buy-in were critical. Implementation worked best when there was strong leadership advocacy, hands-on support, and clear guidelines to help staff understand how DMBC fit within their workloads. In sites where leadership involvement was minimal, they saw lower staff buy-in. In these settings, staff often viewed DMBC as optional work or less interested in trying it, and that led to fewer clients being onboarded and less consistent engagement overall. Our second broad theme focuses on the strategic opportunities leaders identified that could strengthen and sustain DMBC implementation. One key area was the need for more contextualized and flexible practice. Leaders emphasized adapting DMBC to each servicing client, for example, tailoring processes for neurodivergent clients. This flexibility would allow providers to choose relevant measures and adjust timing for complex cases, instead of using a one-size-fits-all approach. Another opportunity was system integration and streamlining. Many leaders felt that integrating DMBC into Connect Care, a province-wide EMR system, would improve consistent use, reduce measure duplication, and make collaboration across care teams smoother. They also pointed to the need for targeted training and capacity building, ensuring training is role-specific, ongoing, and responsive to each site's evolving needs. Finally, sustainability and organizational support was seen as essential. Support, particularly looking at long-term funding, leadership commitment, and gradual rollout to build confidence and engagement over time was most important. I'll pass it along to Leah to speak about the qualitative insights from providers now.
Thanks, Karen. So as Karen mentioned, we held focus groups and interviews with providers who are using DMBC with their clients. And there were many findings way more than what we have time for today, but we'll just focus on three main themes for this presentation. So in relation to the measures in the online platform, providers shared that the measures included in the assessment battery should align with what's already used in their clinic and their practice to reduce overlap of information. They appreciated the amount of health data that the measures provided, but they felt that the number of areas measured in the platform was quite overwhelming for some of their clients, and they wanted the ability to customize which measures youth complete based on each client's individual needs. In terms of the results of measures, providers were able to use those results to inform their treatment planning and their goal setting on an ongoing basis. They also talked about the value of using results to support the ending of treatment and continuity of care, especially when youth were moving between different providers or different clinics. There were many concerns about the amount of time that it took providers to review results from DMBC, which indicates that providers need allocated time for DMBC in their schedules and possibly a reduced number of measures. And finally, their perspectives on the implementation of DMBC are consistent with what we heard from leadership and what Karen was speaking about. They often mentioned that DMBC was implemented at the same time as other organizational changes, as well as changes in the larger Alberta healthcare system, like the transition to Connect Care, which really affected their readiness and the time that they had to learn and implement new ways of working. So in order to improve the implementation and the uptake of DMBC, they talked about the importance of clearly defining providers' roles, having ongoing training, and needing that support from leadership. And they felt that integrating DMBC into daily workflows was essential to sustain implementation. In all of the focus groups and interviews, there were certain implementation barriers that were mentioned consistently across all of the settings. And these barriers really affected how providers use DMBC in their practice and their perspectives on the sustainability of DMBC over the long term. The first two were mentioned in the previous slide. Measuring too many areas can lead to assessment fatigue for both providers and clients. And we definitely found that this did reduce engagement in DMBC over time. DMBC also created additional work for clinicians as it wasn't fully integrated into their existing workflows and their electronic medical records. And finally, providers talked about the limited availability of certain resources that were required to use DMBC, such as technology at the clinic, administrative support, and time in their schedules to support some youth who needed help to complete their assessments. Altogether, these barriers suggest that the successful and the long-term implementation of DMBC really depends on how DMBC fits within clinical workflows and systems and whether providers have certain resources available to them. So moving on to our data from interviews with emerging adults, there were certain perspectives that were shared by most youth that we spoke with in terms of their experiences with the measures themselves. They liked that the measures were comprehensive. They felt that completing measures enabled self-reflection, and sometimes it highlighted areas of concern that they weren't aware of previously. When emerging adults use the platform on an ongoing basis, they appreciated the ability to track their mental health and see the visual of their progress. Another common theme was that DMBC and providers' access to their results sometimes improved communication and collaboration between youth and their clinician. And it also helped some youth to take a more active role in their treatment because they were able to use their results as conversation starters. In terms of barriers, emerging adults shared some of the same issues that were raised by providers. They liked that the platform covered many topics, but some of them felt that certain measures just weren't relevant for their personal circumstances. They also felt that completing certain measures and engaging in DMBC in general could be mentally draining for young people with mental health concerns. And finally, many participants felt that certain questions in the measures were poorly worded or they lacked context, and sometimes they weren't necessarily developmentally appropriate, which could make it difficult for some of them to understand the questions and complete the measures. So based on all of that data from leadership, providers, and youth, we developed 10 policy recommendations for DMBC. The first 5 are related to the larger health system and clinical settings. They include the ability to customize measures so that they align with existing workflows and electronic medical records, support and engagement from leadership, funding for implementation and administrative support, ongoing provider training in DMBC, and embedding DMBC within a rapid learning health system so that the process of DMBC can be adapted and improved over time. The next 5 are related to clinical governance and youth-centered standards. These include aligning DMBC with stratified care policies, including youth who use DMBC in co-design to improve usability and engagement, which Karen is going to talk about next, establishing clear policies around consent for DMBC and confidentiality, ensuring that the delivery of DMBC is equitable, culturally responsible, and developmentally appropriate, and developing protocols for responding to risk that is identified in these online platforms. I'm going to pass it back to Karen now, who's going to share some of our ongoing co-design work.
Thanks, Leah. Overall, our findings indicate that DMBC holds a lot of promise, but several barriers constrain its benefits. Addressing these challenges require collaborative solution building, and these provide foundations for our upcoming co-design study, which focuses on developing practical, context-sensitive strategies informed by those who really use and deliver DMBC. We will be using a multi-method user-centered approach to actively involve emerging adults, providers, and leaders in developing practical solutions. We anticipate beginning this month, and the study will approximately last 3 months. We will use purposive sampling to recruit participants well-positioned to provide relevant perspectives based on their experience with care delivery or service use. We will recruit approximately 5 to 12 emerging adults alongside 8 to 30 providers and leaders across participating sites. These participants will come from 2 Calgary-based specialty mental health clinics that serve emerging adults and young adults. 2 goals guide our study aim. Our primary goal is to inform and support practice change in EA or emerging adult mental health services through co-design strategies that strengthen the relevance, feasibility, and uptake of DMBC. And our second goal is to evaluate participants' experiences and engagement with the co-design process to improve future co-design initiatives. This study will involve 10 semi-structured co-design sessions, 5 with EAs and 5 with providers and leadership together. Each session has a targeted objective and interactive activities and discussions. The entire process will produce 4 key outputs, which will be piloted in the participating clinics. I will get into the objective and outputs in the next couple of slides, but data collection and analyses will be iterative, combining surveys with rapid, qualitative methods to refine session content and outputs in real time. All sessions will be recorded for analysis. The approach is agile and responsive, ensuring that feedback from participants shape the design and implementation of DMBC strategies. This slide, it outlines how EAs, emerging adults, providers, and leaderships participate in parallel co-design sessions, each addressing the same objectives from different perspectives. EAs first take part in standalone sessions focused on orientating to the co-design process. Both groups then separately identify meaningful measurement domains across the care pathways, discuss how results should be shared and used in care, and explore how complex and sensitive measures can be integrated appropriately. Providers and leadership additionally participate in a focus session to translate these insights into clear and actionable implementation plans. The final sessions bring both groups separately to review co-design outputs and share reflections. The 4 key outputs we aim to develop are a structured table that identifies the prioritized domains and key measures to use, Second, a key orientated resource for meaningful measure integration to guide them on when and how to use measures. Third, a clinical job aid for providers to guide them how to integrate DMPC into day-to-day clinical workflows. And fourth, an implementation plan co-developed with providers and leadership on how DMPC can be appropriately implemented at organizational levels. Next, I'll pass it along to Gina to speak to the key takeaways from today's presentation.
Thank you, Karen and Leah, for excellent presentation. I'm just going to talk a little bit about the key takeaways. And I do want to say that we're really excited about the co-design work. And I think our both quantitative and qualitative research with the different interest holders really demonstrated to us that a top-down approach doesn't work so well we when clinicians and young people feel like they don't have choices in what measures to use and how to use them. And so we are really hoping that by co-designing what to use and when to use and where in the process of clinical care that we'll see a better uptick of use of measure-based care within the system. And we're really excited to be working in partnership with two emerging adult programs in Calgary. So happy to come back and share with you what we've learned at a later point. But the key takeaways from our talk is that, we have heard from leaders, providers in EAs, how they think we could best support the implementation of digital measurement-based care and how to use PROMs within their clinical care setting. As I said, I think the most important finding is that unless there's leadership support and a way of ensuring that how the data is collected and where it's stored, that it's not replicated, that doesn't feel like clinicians have to enter that data in multiple places, because that can be a real huge burden to them that then hinders them from being able to do this in their day-to-day practice with clients. So a potential way to increase uptake among all the groups was to regularly collect feedback, both from providers and EAs, and really work with them to think about how to share with each other. So it's not just about completing a set of measures, and then the clinician has access to the outcomes of those measures. It's how do I go back now and in addition to, using clinical judgment and understanding and relationship that one has with the client, how do I now talk about how they might have, scored on these different standardized measures? How do I probe if there are differences or similarities or fluctuations in symptoms? And so what we heard is how important that is. And young people, as Leah shared, that's important to them. They want to be able to talk about their results and for it to be a collaborative process and one that's iterative as well. We also heard, and we have again many of people on our team like Karen who are really good at implementation and are also clinicians themselves that really have an understanding of how to do that hands-on education and that training and being available to really help support people to think about how to use measurement-based care, the platforms, the apps, all of it is really important because clinicians aren't trained to know how to use measurement-based care. That isn't something that's necessarily embedded within their education, their degrees or professional degree programs. So we're excited for the upcoming co-design work with emerging adults, with different disciplines who provide mental health services and organizational leaders. Because if we don't have their buy-in about what we're co-designing, then this won't work. So this work really will help us to continue to think about how to refine measurement-based care, how to make it not only implementable, but sustainable. Because ultimately, we want whatever we're doing to be sustainable and become part of routine care rather than something that we're doing, just for research purposes and then pulling out in a couple of years. And we hope that, of course, all of this will improve workflow and also lead to better outcomes for young people. We have we wanted to share with you our published work. We're certainly not the only ones who are publishing in this area. There's lots of great work that's happening in this area across the globe. We just wanted you to see the papers that we've published or are under review, or I think we might have moved to two that are currently just about to be submitted. But we're really excited to share some of the work that we've been doing, and it's accessible. If you have any difficulties locating them, we're really happy to send them to you as well. And I again want to really just express our gratitude for being invited to come today to share our work. We are open to any questions and feedback and comments about and to learn from all of you. What are you doing in your context that we can learn from as well? So thank you so much, Karen.